I'm Dr. Jean Jose, Department of Radiology, University of Miami, Medical Director of the Lennar Foundation Medical Center. We're here to introduce you to the fundamentals of musculoskeletal ultrasound imaging. I'm joined by Louis Payro, Ultrasound Supervisor for the Lennar Foundation Medical Center, and Nikhil Patel, medical student of the University of Miami School of Medicine, that will serve as our patient.
Hey y'all, this is Richard Wang, radiology resident. I'm going to be going over basic MSK ultrasound of the wrist and hand. First, I'll go over some basic concepts of MSK ultrasound, and then I'll go over anatomy and evaluation of the ventral and dorsal wrist, followed by examples of pathology, and finally a video demonstration. This is for educational purposes only, and I have no financial disclosures. The probe should be referred to as in long axis or short axis depending on the orientation relative to the tendons, ligaments, muscles, or nerves. At the bottom left, we can see the tendons and ligaments both have an echogenic fibrillar pattern. At the top right, we can see that muscles have an hypoechoic pattern with echogenic fibroadipose septae. At the bottom right, we can see that nerves have a fasciculated appearance. Shown are the three main transducers that we use in MSK ultrasound. The left two are high-frequency linear transducers, and the right is a low-frequency curvilinear transducer. High-frequency transducers are great for superficial structures, and low-frequency transducers are better for deeper structures. The leftmost is sometimes referred to as a hockey stick. It has a smaller footprint and is great for smaller spaces. For the hands and wrist, we'll use the two high-frequency linear transducers. I'll briefly go over anisotropy as it is the most important artifact in MSK ultrasound. Tendons and ligaments both have an internal parallel arrangement. Sound beams must be perpendicular to capture this. Small deviations can make it seem like there's pathology when there isn't. The bottom right image is an example of anisotropy at the insertion of the supraspinatus tendon. On the ventral side of the wrist, the main structures we'll be evaluating are the flexor tendons, the carpal tunnel, the median nerve, and the transverse carpal ligament. Look for bony landmarks at the proximal carpal tunnel, the scaphoid tubercle on the radial side, and the pisiform on the ulnar side. Ideal imaging should have one edge of the scaphoid and the other at the pisiform. There are 9 flexor tendons within the carpal tunnel, 4 flexor digitorum superficialis tendons, denoted by S, 4 flexor digitorum profundus tendons, denoted by P, and 1 flexor pollicis longus tendon, denoted by FPL. The last structure in the carpal tunnel is the median nerve, denoted by the big white arrow. Adjacently superficial to that is the transverse carpal ligament that connects the scaphoid and trapezium to the pisiform and hamate. There are 6 compartments for the extensor tendons of the wrist. I won't go over all of the extensor tendons, but I'll give some tips for remembering some of them. At the first 2 compartments, the order of the tendons is LB, LB. So APL, EPB, ECRL, ECRB. The second and third compartments are separated by Lister's tubercle. Compartment 5 is for the pinky, the 5th finger. The 6th compartment is the most ulnar-sided compartment, and that controls the extensor carpi ulnaris. You can also look for a joint effusion at the dorsal recess of the radiocarpal joint. You can also examine the scapholunate ligament. You want to place the patient's hand in ulnar deviation and start from the level of Lister's tubercle and sweep distally. Here's a couple of examples of wrist effusions. On the left image, there's some fluid at the dorsal recess of the radiocarpal joint. On the right image, there's some fluid at the dorsal recess of the distal radioulnar joint. These images show tendinosis and tenosynovitis of the flexor tendons of the finger. You can see the tendon itself is thickened with surrounding fluid. The middle image has color Doppler showing hyperemia. On these examples, the top 2 images show tendinosis. The top left shows a long axis view of a hypoechoic thickening of an extensor tendon over the proximal phalanx. The top right shows hypoechoic thickening of a tendon, in this case the flexor carpi radialis. On the bottom image, it shows a long axis view of the flexor carpi radialis tendon with hypoechoic thickening and a focal anechoic defect at the arrows demonstrating tendinosis with a partial tear. These are some examples of carpal tunnel syndrome. On the top left, it is a short axis view of the median nerve showing hypoechoic nerve enlargement. On the top right, this is a long axis view of the median nerve showing hypoechoic nerve enlargement. On the bottom, it is a long axis view of the median nerve with an anechoic ganglion cyst pushing on the median nerve. These are two images of the volar wrist at the scapholunate interval. On the left, the image shows a normal echogenic fibrillar scapholunate ligament. On the right, this shows a partial hypoechoic scapholunate ligament disruption.
For examination of the wrists, fingers, and feet, we like to use a linear small footprint transducer. This is an 18 megahertz transducer. We begin by examining the volar aspect of the wrist. We will look at the flexor tendons in both short axis as they extend from the distal forearm through the level of the carpal tunnel. We will follow the median nerve and also the flexor inoculum and transverse carpal ligament. We will ask the patient to move their fingers, and we will do a cine loop to make sure that there's normal tendon gliding. We will follow the individual tendons of the thumb and individual digits in both short and long axis to look for any fluid around the tendon and any tear of the tendon. We will turn the patient's wrist and we will examine the dorsal extensor compartments. There are 6 dorsal extensor compartments, and we will evaluate each one in long axis and in short axis. Lastly, we will take a look at the dorsal aspect of the wrist. We will evaluate for a wrist effusion, and we will place the transducer over the dorsal aspect of the scapholunate interval to evaluate the scapholunate ligament.